Okay, so hello everyone. I was on the ICU 2 a couple of days back, and we had a patient there who seemed to be having a severe coagulopathy with very, very blue feet and was getting an AKI. And we were discussing on the unit whether potentially this might be an atypical presentation of or a secondary feature of COVID-19 infection in that patients may be getting hypercoagulable. So I did a quick PubMed Central search just to see if there's anything out there in the literature on this and whether we should be treating it. The interesting thing about this patient was they had respiratory features consistent with a pulmonary embolus, in that they were mechanically very easy to ventilate but still very hypoxic, and also with quite a significant gap between their alveolar end tidal measured CO2 concentration and the CO2 in their blood, in that we were ventilating them rapidly, but they were just not clearing their CO2. There's quite a big gap between the two. And as well, the patient had what looked like were very, very ischemic blue feet, but with present tibial pulses and only one dorsalis pedis that was absent. So it's like the question that went through our mind on the rounds was, had this patient basically clotted off all their microvasculature, but their major blood vessels were remaining open? And so that was just the question, are we missing something, and should we be anticoagulating a subset of patients? So I just did a quick PubMed Central search, and this article came up. It's published, or going to be published, in the Journal of Thrombosis and Hemostasis. The article is free to access, so just search for it and have a look. It's at the pre-publication stage, so it has been approved. It has been it's gone through the editorial process, but it's got a couple of typos and it's not formally set up right, so the graphs and tables don't look very, very good. And it's looking at whether anticoagulant treatment is associated with decreased mortality. It's not the best study, and we'll go into the ins and outs of that as why, but it might be something that we want to think about for some of our patients, and I'll tease out the bits of information and bring it all together. There is some evidence that potentially COVID-19 patients are becoming hypercoagulable and clotting off their microvasculature. I received a message from a colleague who's a director of one of the Belgian ICUs, and what they've been reporting is about 60 to 70% of their patients are having DVTs, and they're big DVTs. And that's just anecdotal evidence. We have been seeing on the ICU a pattern of profound refractory hypoxia, similar presentation to a PE, and patients who have very good lung compliance as well. So it's not like they've got stiff, bogged down lungs. They're ventilating fine. They're just really, really hypoxic. And also, we're seeing very, very high AKI rates on the unit. Now, that could be because we've been running our patients relatively dry to protect their lungs, but the filters are also clogging up really frequently. And this is all just anecdotal at this stage. So this is just sort of a pattern or a trend that we may be seeing, and that's sort of what has triggered the thought process in my mind, and why I decided to have a look at this article. So it's a retrospective analysis from Wuhan in China. All the patients have proven COVID-19 on RNA analysis, and they defined all of the patients who were in the study that looked at were defined as having severe COVID-19, which is the presence of any one of the three characteristics of a respiratory rate of 30 at rest, oxygen saturations of less than 93% at rest. It doesn't mention whether or not they received oxygen therapy, and a PaO2 FiO2 ratio of less than 300 millimeters of mercury. So to put that into context, that probably encompasses every single one of our ICU patients. They then calculated something called the sepsis-induced coagulopathy, or SIC score, and they modified it a little bit. It would seem, and this is a new territory to me, that SIC is a less serious version or sort of a precursor to disseminated intravascular coagulopathy. They defined the presence of SIC as a score of greater than or equal to 3 based upon this chart, where all they looked at was platelets, the INR, and the sequential organ failure assessment score, or the SOFA score. SOFA score is a a score that looks at, I think it's 5 or 6 parameters. I'll show you the score a bit later on presentation to ICU. When you see the score, you'll understand that every single one of our ICU patients is scoring at least 2 points on the SOFA score. That's the kind of parameters. So I almost feel like for our ICU patients, we can just ignore the SOFA score, and we could say that SIC is present in any of our patients on ICU who've got an INR greater than 1.4 or a platelets count of less than 100, because that would automatically tip them up to a SIC score of greater than or equal to 3. So where does SIC come from? I haven't spent long looking at the journals, but it seems to be a new category of coagulopathy associated with sepsis. This was a 2019 publication, but I think the first sort of inkling of this coming out was around 2007 or 2009. But this is from the journal Clinical Medicine, and basically what you can see from the curve is that you sort of get the beginning of infection, and as time progresses you start to get first the release of tissue plasminogen activator, and then you get the secondary production. You basically develop this SIC that can then develop into full-on DIC. So it's sort of like a pre-phase of DIC associated particularly with sepsis. So the original SIC criteria are on the left. So you can see it looks at the platelet count, the D-dimer, the prothrombin time, the fibrinogen level, and the SOFA score. For reasons that aren't entirely clear in this study, they seem to have ignored the D-dimer score in their SIC scoring, but later on in the paper they've specifically mentioned D-dimers, and I'll show you that data. And they've ignored fibrinogen, and I don't know why, except for I guess they can say they're ignoring fibrinogen because it's not relevant to the definition of SIC. It's only developed to the relevant to the definition of DIC. But that there on that side is the difference between the core definition for DIC versus the core definition for SIC. So it looks like they've got a simplified score and only just taken a couple of the points out. So this is the SOFA scoring. So this is a sort of a generic tool that's used as a mortality calculator for admission into ICU. And you can see you've got the PaO2, FiO2 rating, coagulation study in terms of platelets, liver bilirubin level, cardiovascular hypotension, and the CNS scale, or their GCS, in the what you think it would be in the absence of sedatives. So I guess you'd say what it was just before you intubated them, and then whether they have renal failure. Now remember, you just need a SOFA score of 2 to get onto being into the SIC category, and you can see how you can almost instantaneously get every single one of our ICU patients. So with regards to patients who are in the intensive care unit, I think it's relatively safe to say we can ignore the SOFA score and just look at platelets and INR, or potentially D-dimer. So what are the methods? So it's they looked at all patients with what they had predefined as severe COVID-19 based upon the criteria that I mentioned before, and they defined treatment in terms of treatment versus non-treatment as unfractionated heparin or low molecular weight heparin for 7 days or greater, and they just looked at the 28-day all-cause mortality. So the results, they had 449 patients at this hospital, of which 181 were females and 268 were males. Again, it seems that COVID-19 seems to have a predominance for making male patients more unwell. 272 of which had pre-existing comorbidities, of which the main ones were hypertension, diabetes, and what they describe as heart disease. They don't specify whether it's ischemic heart disease or another form of heart disease, but I think it would be safe to assume it's ischemic heart disease. And of that population, just under 199 patients received 7 days of heparin, of which 94 received low molecular weight heparin at a dose of 40 to 60 shouldn't be grams, that's milligrams of enoxaparin, and 5 received unfractionated heparin at a dose of between 10,000 to 15,000 units per day. This table has been lifted straight from the paper, which is why you can see it's a rough draft. That's why there's a typo there. So you can see for those patients that have a raised SIC score, in terms of if you treat them with heparin compared to whether you don't treat them with heparin, there's a nearly 24% decrease in mortality that is statistically significant. And that, I guess, is their take-home message from their paper, that we should be treating these high-risk patients with heparin. The other thing that's a bit iffy, I think, if you go back and have a look, is if you look at the dose of heparin, it sort of sits, they haven't been quite clear whether the non-treating with heparin patients have received no heparin at all, as in they've not even received prophylactic heparin. And I think that is a real confounder in this, and that might just be something we want to bear in mind if we start to draw any conclusions from this. The other thing, which is, although that D-dimer is mentioned within the DIC component, it doesn't form part of the SIC component. So it looks like they analysed it completely separately. And the thing that I took home from this is, if you want to have a look at this chart, so they just defined it as greater than upper limits of normal. That's what ULN is. So D-dimer of less than or equal to 1 is a... would be sort of essentially a normal range of heparin. What's interesting is that they only had 34 patients that didn't have anything, but note that there was a decrease in mortality with those who received heparin, but the numbers are so small to make it clinically significant. With the other groups, for where there's a much greater population number and therefore a bit more chance to draw some conclusions, there isn't really much of a difference between whether they did or did not receive heparin until you start to get those who have a severe D-dimerise of greater than 6 times the upper limit of normal. Now, I think in our hospital, and well, I can't remember what the numbers, but if it's 500 is the upper limit of normal, then 6 times that will be a count of 3,000 or more. So someone might want to have a look on the system and see. But in that instance, when they get to really, really severely elevated raised numbers, you do start to see a significant difference. And now you get your p-values that are going under 0.055%, and with heparin it's only 33 and 33%. The other thing to note from this is, and I think another take-home message is just how severe this disease is, in that with patients with what they define as severe COVID-19, which to my eyes doesn't look that severe, the mortality is very, very high. But maybe one of the things we might be looking at with some of our ICU patients is, although D-dimer is very non-specific and is a terrible indicator of what's actually going on, but if it is severely raised, whether we should be anticoagulating our patients, which I don't know if that's what we're doing at the moment. So what are the discussion points for this? Well, the first is that there's a webinar that's going to be happening tomorrow looking specifically at the role of coagulopathy in COVID-19, and there's 3 specialists who are going to be talking on that. I won't be able to listen in on that webinar because I'm going to be at work, but definitely one of us should try and log in. I think Ruth might have sent the link through the WhatsApp group, so at least someone could please log in on that and maybe see if they either mention this paper and what they think about it, or whether there's some other information out there. I've not really had an awful lot of time to scour all the literature. There's issues with this paper in terms of the dose and the duration of heparin. They classified it as 7 days or less than 7 days and none. And it's a bit difficult to see where they sit between treatment dose and prophylactic dose. So where we are quite keen on giving almost all patients in both ICU but in the hospital prophylactic heparin, it's not entirely clear what they were doing in China. The second thing is the potential that we might want to be looking at the role of D-dimers and treatment dose heparin, in that whether if we have a patient with COVID-19 that's come onto the intensive care unit, whether we should do a D-dimer assay on them, and if it is gloriously raised, we should start to anticoagulate them either with an oral anticoagulant or whether just with treatment dose subcutaneous low molecular weight heparin. I think that's going to have to be a clinical discussion among us as a group, or just left it to the individual. And we have to be very cautious in the interpretation of this study. It's got millions of flaws with it, but I wonder if it's gesturing us towards, so rather than specifically saying we should do one thing or another, but whether it forms part of the drive to sort of cast our mind to whether these patients with COVID-19 are hypercoagulable and clotting things off, and maybe that might be one of the reasons why it's such a difficult disease for us to treat. So that's the end of it. That's my review on the article. You can get it on PubMed. It's free to access. I think with the way things are going with social distancing, for those that can, this should probably be the best way we can to disseminate articles. I don't think doing a formal journal club is going to work with our timings, but maybe if people like this, that would be the way forward, in which case ping me a message through the group and I will teach any of those who don't know how to do this how to do it. It's very, very straightforward. Okay, stay safe, and that's it from me.